We're going to start the lectures on the vertebral column, starting with the cervical spine anatomy and positioning. The cervical vertebrae anatomy starts out with the 7 cervical vertebrae of the neck. The cervical vertebrae are very special in that they have transverse foramen located on the transverse processes. They have a bifid spinous process, unlike the rest of your vertebrae from the thoracic down through the lumbar. The very unique feature with the cervical vertebrae is that you'll see the zygapophyseal joints are located at 45-degree angle from mid-sagittal plane. The first two cervical vertebrae are atypical in their shape. They are very special in their design. C1 is known as the atlas and C2 is known as the axis. C7 is also very special, is that spinous process is known as the vertebral prominence, and it is not bifid like its other cervical vertebrae. So starting out with C1, the atlas, very special. It has an anterior arch, a posterior arch, no bifid process. It has 2 transverse processes, and C1 actually has no vertebral body. And the superior articular process receives the condyles from the occipital bone, the skull. C2 is the axis. It has a conical process called the dens, or also known as the odontoid. It is on the upper anterior portion of the vertebral body, in which C1 sits on top of C2 at the odontoid. So moving down to C7, because that is atypical as well of the other vertebrae. It has the vertebral prominence. It's the spinous process that's posterior. It's very easily palpated. You will use this as a positioning landmark for several positions that we do as x-ray techs. So moving into the positioning of the cervical spine, starting out with the AP dens, known as the Fuchs method. So the Fuchs method is used if there's a possible cervical fracture or a disease is suspected of the upper part of the dens. You're going to use an 8x10 cassette, crosswise or lengthwise. Your KVP will be set at 75, and we're going to use the center cell of our AEC. We'll use 40-inch SID, centering perpendicular to the image receptor, entering right below the chin through the mid-sagittal plane. The patient is going to suspend their respiration. The patient is supine with their chin extended until the chin is actually vertical to the image receptor, so perpendicular. The chin and mandible will be parallel with our central ray. The collimated field should include the entire dens or odontoid, the lower border of the mandible and base of the skull, and the dens will be seen within the foramen magnum, which is the center of our imaging field. So looking at our image here, we can see the outline of the foramen magnum, and the dens or the odontoid is shown right in the middle. The C1, is above, wrapped around the dens, and C2 is in which the dens is attached to. Alright, so this is the most common position to see the dens. This is known as the open mouth, AP, for the atlas and the axis, or C1, C2. This is also a 8x10 cassette collimated area, even smaller than an 8x10. We are going to use a technique of 75 kVp and approximately 26 MAS, 40-inch SID. Central ray is perpendicular to our image receptor, entering midpoint through the open mouth while the patient is saying ah. The patient is supine. Align the upper edge of the teeth, so the upper incisors, to an imaginary line from the tip of the teeth to the mastoid tip or base of the skull. So we're going to align through the tip of the teeth through the mastoid tip right here, and which is also aligned to the base of the skull. The patient will open their mouth and say ah as you make the exposure. So again, we're going to see similar anatomy. This is all about seeing the dens. We also want to see the entire articular surface of C1 and C2. We need to see that interspace, the joint space. We need to see superimpose occlusal plane and the upper incisors, so with the base of the skull and the tip of the teeth need to be superimposed. The patient's mouth must be wide open, and the shadow of the tongue, we should not see that over the dens. No rotation. We can see that there's no rotation here by the equal distance between the rami of the mandible and to the body of C1 and the lateral processes or the lateral masses of C1. Alright, this shows where the odontoid fracture is. It shows subluxation we can see in this CT scan. But right here, the odontoid is fractured from the C2. So the AP axial C-spine. This is also done on an 8x10. The technique is 75 kVp using the center cell of AEC at 40 inches. Your central ray should be centered at C4 and angling your central ray 15 to 20 degrees cephalically, so towards the head. The patient will suspend their respiration. The patient can be upright or supine for this particular projection. Align the mid-sagittal plane to be along with the long axis of the image receptor, centering at C4. The mid-sagittal plane of the head is perpendicular to the image receptor. Extend the chin to place the occlusal plane perpendicular to the tabletop. So we're going to have at the base of the skull and the tip of the chin to be aligned perpendicular to the image receptor. So we're going to see C3 through approximately T2, so T1, T2. The mandible and the base of the skull, so the occipital bone, are completely superimposed. You have open joint spaces, intervertebral disc spaces. The spinous processes are equal distance to the pedicles. So your pedicles are right here. They are equal distance. The spinous processes are right down the midline of the spine. No rotation, as we can see, equal distance of the mastoid processes. The lateral C-spine is done to demonstrate the zygapophyseal joints of the C-spine. Zygapophyseal joints are very important to know. You must know about the zygapophyseal joints and the intervertebral disc spaces, as well as the intervertebral foramen. We are also using, again, an 8x10 75 kVp with a 20 MAS at 72 inches. Now, this is very important. Need to know 72-inch SID in order to decrease the magnification because of our OID. Central ray is horizontal and perpendicular to C4. Full expiration. Relax the shoulders, even if it means putting sandbags in the patient's hands to relax the shoulders. Your mid-coronal plane will be perpendicular to the image receptor, while your mid-sagittal plane will be parallel. C4 is in the center. The shoulders at the same horizontal plane and relaxed. The chin is elevated and the mandible is protruded. Collimate to include the sella turcica through the body of T1. If you do not get at least the top third of T1, you will need to do a lateral cervical thoracic projection. So to evaluate your image, you see all 7 vertebrae, 1, 2, 3, 4, 5, 6, 7, and the top of T1. The mandible rami are superimposed over each other and not of the atlas and the axis. There's no rotation. We see the zygapophyseal joints, which are right here, these kind of zigzag shape joint spaces. And C4, C5 are in the middle of the image. Now, in the lateral position, the patient will perform a flexion or extension. Make sure you are ruling out that the patient does not have a fracture before having them flex or extend. We're using a larger cassette for this because of the movement of the neck. A 10 by 12 with a 75 kVp and 20 MAS, 72-inch SID. Central ray is horizontal and perpendicular to C4. Respiration is suspended. The patient is seated or standing. The hyperextension, the patient relaxes their head as far back as possible. Hyperflexion, the patient's chin is brought close to their chest. Here you will see the flexion. The body of the mandible is almost vertical, and you can see all 7 cervical bodies. For the extension, again, we see all 7 cervical bodies, and the mandible is in a horizontal plane as it would for a normal extension. For the AP axial like RPO and LPO, this is an AP axial. We do have the PA axials as well. When an 8x10 is used, we're using a 72-inch SID. Again, same technique that we have been using with 75 kVp. Central ray at 15 to 20 degrees cephalic, centering at C4. Suspended respiration. Now, need to know for this, for an AP axial blike, you will see the intervertebral foramina on the side further from the image receptor that's demonstrated. So the patient in this image here is in the LPO position, so we are actually imaging the right intervertebral foramina. Here we can see the intervertebral foramen demonstrated nice and open in this oblique of the C-spine. You want to see for the AP axial, you'll see the ones that are furthest from the image receptor. The open joint spaces, chin up and out of the way. The foramen are uniformed in size. C1 through C7 are demonstrated, and T1 is also demonstrated. So for the PA axial, you'll see the intervertebral foramina that's closest to the image receptor. Same positioning, the patient is just either an LAO or an RAO, 45-degree rotation as you do for an AP. However, for a PA, your angle is caudally or towards the feet, 15 to 20 degrees. And again, you're looking at the intervertebral foramina that's closest to the image receptor for an RAO or an LAO. Same evaluation that we used for the AP, but this time it's the closest body part is of interest.